So welcome to the third Ting Forum in the 2010-2011 series of lectures and dialogue. Dr. MatÃ.
I'm pleased to be on a panel with somebody from the Correctional Service. I'll provocatively state, however, that I'd be looking forward to find out what is it that the Correctional Service actually corrects. In my view, very little. And furthermore, also a professor who studies the criminal justice system, and I completely agree the justice system is completely criminal and it should be studied that way. In all seriousness, of course, the institutions and procedures of a society very much reflect a perspective. So there's always an underlying perspective. And what I want to examine with you today are the perspectives that underlie our society's legal and social and moral and medical approaches to the treatment of a condition which is obviously of great significance in our society, that is to say, addiction. Now, my work for the last 12 years has been in the downtown east side of Vancouver, which is well known as North America's most concentrated area of drug use. In a few square block area, we have thousands of people who are dependent on injection delivered substances, and they're dependent on them to make them feel better in this world. Although we tend to look upon addiction as something bad, I'm actually here to say that addictions, in a funny way, represent the highest aspirations and needs of human beings. Of course, they also deplete and destroy the organism that engages in the addictive behaviors. But that's not to say that the quest that underlies the addictive drive is misguided. The direction of it may be, but the fundamental and ultimate purposes of it are simply to make us human. And to criminalize and morally condemn such an activity is to completely misunderstand its purposes and its origins. Now, if the success of a physician is to be measured by the longevity of his clients, then I have to stand in front of you and confess to being a complete and utter failure. My patients don't live long. They die of HIV, they die of hepatitis and its complications, cancer of the liver, for example. They die of infections of multiple organs, of the bloodstream, of the heart, of the brain. They die of overdose, they die of suicide, they die of violence. They die accidental death, and very few of them live past their 50s. I will begin by just reading a short segment from the second chapter of my book, In the Realm of Hungry Ghosts, Close Encounters with Addiction. And the epigraph to the chapter is from the beautiful Nobel Prize-winning trilogy, the Cairo trilogy by the ineffably great writer Naguib Mahfouz, who said, "Nothing records the effects of a sad life so graphically as the human body." From behind his lectern at an East Hastings funeral chapel, the elderly priest proclaims the world's farewell to Sharon. Her name was actually Shannon. I'll call her Shannon here. How exuberant and joyful she was. "Here I am, Shannon," she announced as she burst into her room. On seeing her, who could not feel glad to be alive? Behind the family, the mourners are dispersed through the sparsely filled chapel. A group of Portland Hotel, this is the domicile where I worked, are present, along with 5 or 6 residents and a few people I don't recognize. The young Shannon, I've been told, was a model beautiful. Hints of that beauty still remained when I met her 6 years ago, 10 years ago now. Traces gradually erased by her increasingly pallid complexion, sunken cheeks, and decaying teeth. In her last years, Shannon was often in pain. 2 large patches on her left shin were denuded of skin by injection-induced bacterial infections. Reinfection caused repeated skin grafts to slough off, leaving the flesh continually exposed. The exasperated plastic surgeons at St. Paul's Hospital considered further intervention futile. In her chronically swollen left knee, a bone abscess lurked, flaring up every so often and then subsiding. That osteomyelitis was never fully treated because Shannon couldn't endure the 6 to 8 weeks of hospitalization required to complete the intravenous antibiotic regimen, not even when it appeared that amputation might be the only alternative. Unable to weight bear owing to her inflamed knee joint, Shannon became hostage to a wheelchair in her early 30s. She'd propel along the Hastings sidewalk at astonishing speed, employing her strong arms and right leg to boost herself along. And then, after the funeral service, we gather in the parking lot, the staff and some of Shannon's fellow addicted human beings. And I look at this group, and I think, I look at this small cluster of human beings gathered at the funeral of a comrade who met her death in her mid-30s. How powerful the addiction, I think, that not all the physical disease and pain and psychological torment can shake loose its lethal hold on their souls. Nothing sways them from their habit, not illness, not the sacrifice of all earthly goods, not the crushing of their dignity, not the fear of dying. The drive is that relentless. And in fact, one patient said to me once, "I'm not afraid of dying, I'm much more afraid of living." And so the question is why? Now the social response to addiction is to consider it to be a choice that people make. In fact, the entire criminal justice system would make no sense without the assumption that people are making conscious choices. As soon as you realize that people are not making conscious choices, what are we punishing them for? So the very question of punishment implies a conscious decision that somebody makes to be an addict. Now, there's never been a less scientific and more backward assumption in the whole of history. The second assumption is that it's a disease. Now that's sort of the AA assumption and sort of the medical assumption as well. And it certainly has truth to it, because the addicted brain, if you look at it on brain scan, if you study it biochemically, is a diseased brain. But the assumption as to what creates the disease is generally assumed to be, is generally that it's a genetic condition, so people inherit it. Now here's what you'll notice, and I'll address both of those assumptions in a while, but here's what you notice about both of them. They both take society off the hook. Because as soon as something becomes a matter of individual choice, or something that's determined by genes, immediately we don't have to look at who gets addicted and why, for example, certain social groups are much more prone to it. So in the Downtown East Side, 30% of my clients are First Nations origin, whereas they only make up 2 or 3% of the Canadian population. In many of the federal jails across the country, large minority and sometimes the majority of the inmates are First Nations origin. Now, if we assume that these people are making the choice, or if we assume that these poor primitives just lack the genes to withstand the powerful impact of these drugs, we don't have to look at history. We don't have to look at what may have happened in this country and what continues to happen in this country to people of color, and particularly Aboriginal people of color, to induce them along the addictive path. So, right or wrong, the choice hypothesis, which is what the justice system is based on, or the genetic hypothesis, immediately take the focus off society and the social impact on the individual. Now, can we actually understand individuals in separation from the society in which they live? Or do we, in order to understand the person, have to look at the social context? Now, the Buddha knew something about that. He said 2,500 years ago that nothing arises on its own. He said, look at a leaf or a raindrop. He said, and contemplate, he says, on all the conditions that have to be present to bring that leaf or that raindrop into being. Obviously, the leaf contains the sun, photosynthesis, the earth, in terms of the nutrients that go into it, and of course the sky, the irrigation. And when a leaf dies, it returns to the earth and to the sky. So he says you can't understand anything on its own. He talked about the interdependent co-arising of phenomena. He said without the many there cannot be the one, without the one there cannot be the many. That's the perspective that I am taking towards understanding addiction, or indeed any other human condition, to see it in context. And that's what my attempt here today is, to paint you a picture of addiction that looks at the context, that creates the phenomena, rather than to separate the individual and say, you are morally culpable, you are a failure, or you're simply a diseased person for some predetermined biological reason. And that may be called a biopsychosocial view. Biopsychosocial meaning that the biology of human beings is in fact programmed by the psychological and social environment in which they're conceived, carried in utero, born into, develop in, live in, and die in. In other words, to look at an individual is to see society in a microcosmic way. Now, from the strict medical perspective, if you just want to look at it from the narrow medical perspective, what are addictions? And the medical perspective is not wrong so much as it is hopelessly narrow, but it's still useful. So what do we see when we look at addictions from a medical point of view? Well, what we see is a lot of people self-medicating medical conditions is what we're seeing. What do people self-medicate? There was a study with the American Army within the last year in Iraq. Soldiers given a little bit of morphine after a potentially traumatic incident have less preponderance to developing post-traumatic stress disorder. Opiates treat PTSD. Many of the addicts in the downtown east side, the ones that the police spend their time chasing in the streets, are actually people who suffer from severe post-traumatic stress disorder. And that's why they're using the opiates to self-medicate. Why they have PTSD, I'll tell you very shortly. What else do people self-medicate? People self-medicate depression. If you've ever taken Prozac, as I have, for depression, Prozac is intended to increase the levels of serotonin, a brain chemical implicated in mood control in your cerebrum. Well, cocaine also elevates serotonin levels. People use cocaine to self-medicate depression. Now, if you've been diagnosed with attention deficit hyperactivity disorder, as I have, you might call me a compendium of medical problems. I've been prescribed dexedrine, which is a stimulant. I don't take medications anymore. I don't need to. There are other ways of dealing with life, but I did, and I'm grateful, and they help me. What dexedrine does, or Ritalin, is it elevates the level of dopamine, which is another important brain chemical. I'll tell you about it in a while. It actually calms down the hyperactive brain. What does cocaine do? What does nicotine do? Or crystal meth? Or caffeine? It elevates dopamine levels. People self-medicate ADHD. A good 30% of the people in jail in this country suffer from ADHD. That's why they're there. They self-medicated through some substance that happened to be illegal. And nobody knew they had ADHD, and they didn't know they had it. This is not only my personal opinion, I'm talking about population studies here. What else do people self-medicate? Anxiety. What does the alcoholic do? He's anxious, he has a drink. Social phobia. He feels shy, his tongue is tight. He has a drink to loosen his tongue. He's now more sociable, more voluble. People self-medicate bipolar disorder through alcohol and drugs. Through marijuana, people self-medicate anxiety, people self-medicate ADHD, because pot actually calms down the hyperactive brain. So on one level, you can see addictions as self-medications. Very often, self-medications without actually awareness of the condition that's being self-medicated. That's on the medical level. Now let's go a bit beyond, though, and let's look at the brain, the addicted brain. Well, what are people addicted to? First of all, the opiates. Opiates are derivatives of opium, which grows, of course, in Asia and countries like Afghanistan. And the opiates have been used in Chinese medicine and in other medical traditions for thousands of years. What for? Well, for pain relief. Opiates are the most powerful pain relievers that we have. For 7 years, I was the medical coordinator of palliative care unit at Vancouver Hospital, looking after terminally ill people. And thank God for the opiates. Without them, many people would die in great states of suffering. But the opiates don't only soothe physical pain, they also soothe emotional pain. In fact, the same structure in the brain that interprets the emotional significance of physical pain also responds to the emotional significance of psychological pain. And when you do a brain scan on people who are experiencing a moment of emotional rejection, the same part of the brain will light up as if you stuck them with a knife. So opiates are a response to pain. So the first question in addiction is not why the addiction, but why the pain? Because all the addiction substances actually are pain relievers. Cocaine is a local anesthetic, if you will. Marijuana, of course, in palliative care, when people had nerve pain and the opiates and other modalities didn't work, we would prescribe people cannabis. Alcohol, what do you say about somebody who's drunk too much? They say he's feeling no pain. So the addictions are always about relieving pain, and the question is, why the pain? You want to know why the pain? I don't have a single female patient in the downtown east side who wasn't sexually abused as a child. That's why the pain. The men were also abused, if not sexually, although a large percentage was, a large minority was, then physically and emotionally and abandoned and neglected. So there's a surfeit of emotional pain in the hardcore addict. And, well, let me read you this chapter, this segment from later in the book. Detective Sergeant Paul Gillespie, head of Toronto's Sex Crimes Unit, rescued children from the purveyors of internet pornography. He developed expertise in finding where these purveyors were, these people that would put live, streamed videos of their abuse of small children. And you know, of course, it's not easy to find these people, but he made it a job to find them. As the Globe and Mail reported on his retirement from police work, 6 years at that job had not inured him to the horrors he witnessed. And the Globe said, Paul Gillespie still can't get used to the sounds of crying and pain in the graphic videos of children being raped and molested that he's seen all too often on the web. It's beyond horrible to listen to the soundtracks of these movies, said Canada's best-known child porn cop. But it's the silent images of desolate children that tear most at his heart. They're not screaming, just accepting, he said, of the infants captured in these pictures. They have dead eyes. You can tell that their spirit is broken. That's their life. Now, there's 2 points to be made here. One is the dead eyes. What's that all about? Well, what that is all about is that the child who's traumatized has got very limited means of surviving the trauma. One way to survive it is to deaden his emotions, so because otherwise they're too overwhelming, he can't live with that much pain. So people shut down emotionally, and when they do, they stop developing. Because for emotional development, you need emotional openness and vulnerability. So the average addict in the downtown east side functions on the level of a 2- and 3-year-old developmentally. Doesn't matter how smart they are, how street savvy they are, on the emotional level, they're stuck in toddlerhood. The decisions they make reflect that, because their brains stop developing at that point. That's the first point. The second point is if that same policeman, instead of quitting the police force, had transferred to the drug squad, who do you think you'd be chasing in the streets? Those same kids 20 years later, because they're the ones, according to all the statistics and all the studies, become the drug addicts. Essentially, what we're doing in this country with our so-called justice system is we're punishing people and jailing them for having been abused in the first place. And this is what the Canadian government is now spending $10 billion on, of your tax dollars at work, building more jails for these people, while they're starving the social system of support for kids with learning disabilities, kids with family problems, kids with behavior problems. Those services are being cut in the name of economic what? That's the country we live in. So, these people are all traumatized. That's why the pain. If you want to take it a step further, we have to ask, well, why do people respond to a derivative of a plant that grows in Asia? How come it works? Well, on a brain physiological level, it works because we have receptors for them. We have molecules on the surfaces of our brain cells and our body cells that receive these opiate molecules, and together the opiate and the receptor tell the cell what to do, and that's why they're effective. But why do we have receptors for a derivative of a poppy plant? Well, of course, the answer is we don't. We have receptors for our own opiates. And there's a term for that. Our own opiates are called endorphins. You've heard the term endorphins. Endorphin simply means endogenous morphine-like substance. So we have our endogenous, internal, nature-given opiate system. Why do we have that? Well, it has many functions in the body. I'll list you only the three most important ones as it pertains to addiction. First of all, they're pain relievers, physical and emotional pain relievers. You have to have pain in this life. Pain is an important warning that something is dangerous to you, whether it's physical or emotional pain. You also have to have some internal pain relief because too much pain is unbearable. So there's a balance. So we have opiates to soothe our pain, number one. Number two, opiates are the reward and pleasure chemicals. So when you have an ecstatic, gleeful state, an orgasmic experience, whether physical or emotional, you have opiates released in your brain, the endorphins released in your brain. Now that's important for human life because without pleasure and reward, life becomes, well, as you can imagine, rather difficult. The third function of opiates is also the most important one. It can be summed up in one word: love. Without opiates, there's no experience of connection, attachment, and love. Now, that's not a luxury in life. In fact, love is a basic emotion without which life is impossible. Because without the nurturing connection of the parent to the child and the child's drive to attach to the nurturing adult, life is unsustainable. In the laboratory, when you rear infant mice and you knock out their opiate receptors, they will not vocalize distress when they're separated from their mothers. Now, what happens to a baby mouse who doesn't vocalize distress when mother is absent? Well, death is what happens. In other words, we're talking about a brain system without which life is impossible. Now, I want you to consider the following question. If a human being comes to the conclusion, for whatever reason, that without this particular substance, he or she will have no experience of pain relief, pleasure and reward, love and connection, just exactly how are you going to take that away from them? By putting up a billboard saying, just say no? A la Nancy Reagan, you know? So the opiate addiction is powerful precisely because it seizes hold of or arises in the brain system without which life is even theoretically inconceivable. Same with the dopamine system. Dopamine is another brain chemical, I mentioned it to you already. It's essential in motivation and incentive. Dopamine has to flow if you're going to do something. Again, with a mouse experiment in a laboratory, you have this little mouse, you put a pellet of food in its mouth, it likes it, it tastes it chews it, it swallows it, enjoys it. But you take the food and you put it 3 inches away from his nose, he won't budge to eat it. In fact, he'll starve to death rather than eat. Why? Because genetically, they knocked out his dopamine receptors. And with dopamine, there's no incentive to do anything. So dopamine flows whenever you're seeking food, seeking a sexual partner, exploring a novel environment, exploring a novel object. Without dopamine, there's none of that. I want you to imagine your life without incentive, motivation, curiosity, vitality, all those things that dopamine gives you. And then you discovered crystal meth or cocaine. Crystal meth, you know, food seeking will increase your dopamine levels by 50%, sex by 100%, a shot of cocaine by 300%, and crystal meth by 1,200%. Now imagine a kid then who, for whatever reason, comes to the intuitive conclusion, not necessarily a conscious one, that without that chemical, he has no experience of vitality, curiosity, aliveness, motivation, incentive. How are you going to take that away from him? By putting him in jail? By punishing him? by giving him a lecture on the evils of drugs? There are a number of brain circuits involved in addiction. The opiate and pleasure, reward, love, connection, pain relief circuit being one of them, the dopamine circuitry of incentive and motivation being another. All the drugs of abuse elevate dopamine levels. Other brain circuits involved are emotional self-regulation, impulse control. Impulse control is the capacity to not to act on an impulse. All of us have impulses. But we also know that it's not always good to act on them. And there's a circuit up here whose job it is to regulate impulses. It's also the brain circuit that most commonly, when you do brain scans on drug addicts, that's not functioning well. So the addict really has nothing to say no with. And as somebody astutely said, the problem in addiction is not lack of a free will, but lack of a free won't. So you're looking at people whose brains are actually not capable, relatively speaking, of withstanding the impulse. Now, other circuits are also involved. I'm not going to go into them all. I just haven't time. The real question is, what makes somebody susceptible to the addiction? Because along with the many myths around addiction, one of them is that drugs are addictive. Well, clearly that's ridiculous. How can drugs be addictive? If they were, anybody who tried them would become an addict. But most of you can go into a hospital and be given large quantities of morphine if you need it for a surgical procedure or for a medical problem. And once the problem is dealt with, you're off the morphine and you barely even suffer withdrawal, let alone craving and relapse. So morphine is not in itself addictive. Neither is alcohol. If it was, nobody could drink, but most people can drink without becoming alcoholics. Nicotine, food, sex, gambling, shopping, none of these are inherently addictive. In other words, the addiction doesn't happen because of the substance. So the whole emphasis of the legal apparatus on interdicting the substance, again, is completely beside the point. What really happens is that when you have a susceptible individual and a potentially addictive substance or behavior, that's when the addiction becomes a potential. The real issue that I'm raising here is what makes somebody susceptible. Well, what makes somebody susceptible is simply childhood trauma. Because it turns out that the human brain, for the most part, develops under the impact of the environment. So there's certain predictable things you can do to human beings that'll have predictable consequences. Or to laboratory animals, for example. You can stress pregnant animals in a laboratory in their second trimester and know that as their infants, as adults, will be more likely to use cocaine and alcohol to soothe themselves. Because the dopamine receptors of the brain depend on the emotional states of the mother during pregnancy. Or the person's stress response. Addictions are very often responses to stress. They're attempts to regulate stress. It's when people are stressed that they go off and do something harmful to themselves, like eat too much, or do a drug, or drink. But the stress regulation mechanism of the child's brain is actually programmed by the emotional states of the mother during pregnancy and early in life. Now, I'm not going to go into why the human brain is so susceptible to the environment. You just have to take my word for it. Not that you have to take my word for it in the long term. I'm just telling you that it's not even controversial anymore what I'm telling you, albeit they don't teach it in medical schools yet. But in terms of brain developmental literature, it's totally clear that these essential circuits of the brain depend on the environment for the development. And the necessary condition for the development is the presence of non-stressed, non-depressed, attuned, emotionally available, consistently available parenting caregivers, which is precisely what the addict never had. In large-scale studies in California and elsewhere in the United States, the so-called adverse childhood experiences studies, what's adverse childhood experience? ACE, they call it, the ACE studies. It's physical, sexual, or emotional abuse, death of a parent, a rancorous divorce, violence in the family, addiction in the family, a parent being jailed, a parent being addicted, if I've already said that. For each of these adverse childhood experiences, the risk of addiction in the adult goes up exponentially. So that by the time a male child has had 6 of these adverse childhood experiences, his risk of becoming a substance-dependent, injection-dependent addict is 4,600% greater than that of a male child with no such experiences. In other words, a 46-fold increase. Nothing to do with genetics, simply based on childhood adversity. And these are then the people whose brains are susceptible, who are lacking these receptors, who are lacking these systems fully developed. When they meet a substance, it's the answer to the life's prayer. And one sex trade worker, who I quote in the book, when I asked her what her first experience of heroin was, she said, the first time I did heroin, it felt like a warm, soft hug. That's exactly what it was. Now, it follows, therefore, that choice has nothing to do with it. It's all based on early experience, number one. Number two, genes have nothing to do with it. I shouldn't say nothing. There are genes that predispose to certain behaviors. Predisposed, though, is not the same as predetermined. For example, violence. So the media loves these genetic stories. Why does the media love them? Because the media is there to serve the status quo. And the stories that support the status quo get front-page headlines. So as soon as somebody discovers the alcoholism gene, it goes on the cover of Time magazine. 3 years later, it turns out that nobody discovered anything of the sort. That goes in some back little article on the back scientist pages. Violence genes. Well, there's a gene in an Australian study that showed, indeed, kids who are violent are more likely to have a certain genetic variant in their DNA. But it turns out that if these kids are brought up in families without violence or abuse, they're less likely to be violent than others. So it takes a combination of abuse and that gene to create the violence in them. Same with addiction. Since this book has come out, there's another study in the States that has shown that some kids may inherit a gene that might predispose them to addiction, but brought up in nurturing families, that gene is not expressed, and those kids have no more risk for addiction than anybody else. So genes don't determine. In fact, there's a whole science called epigenetics, which means, epi means on top of. So, you know, the influences that override genetics are far more important than what the genes say themselves when it comes to complex human behaviors. So the genetic argument and the choice argument are simply cop-outs. Cop-outs that prevent us from looking at what actually happens. Which brings me to the First Nations experience in this country, who again make up a disproportionate population, a disproportionate number of the people in the incarceration institutions of our society, despite their relative small numbers in the population. And as Bruce Alexander, Professor Emeritus of Psychology at SFU, and the author of a book that anybody who's interested in addiction, it's going to be the second book that they read, and it's called The Globalization of Addiction. As Bruce brilliantly points out, that on the social level, addiction is all about dislocation. So when people are dislocated, when they lose their place in society, as of course the Aboriginal population was forced to do, when their spiritual ways are invalidated, when their ways of life are destroyed, when their lands are taken away, when their movement is restricted, and then on top of that, when they experience generations of sexual abuse in the Christian-run residential homes, that's when these people become addicted. Nothing genetic about it. There were addictive or potentially addictive substances in North America prior to the coming of the Caucasians. There was peyote, there was tobacco, there were even alcoholic spirits. There was no addiction. After that massive dislocation and historical horror that befell the Aboriginals of North America, that's when addiction becomes their response to all the pain. So when I go to Native communities now, the trauma now is entrenched in the generations. It's passed on multi-generationally. And, you know, I was in Thunder Bay. There was a woman there from a reserve nearby. She said that on our reservation, there are 188 people, 133 are addicted. And it's simply a legacy of what happened to them and what continues to happen to them. And I will stop talking now to leave some time for questions. I have not spoken about treatment implications. But let me say something about that very quickly. Again, the assumption when it comes to addictions is that these people have to hit rock bottom, they have to be punished and so on, then they'll see the light. No, they don't. What's rock bottom for somebody who lives in the downtown east side with HIV, having lost everything? What's the rock bottom that they're going to have to hit? So that is another myth. People don't need rock bottom, they need the very opposite. And Thomas Merton, who's an American Catholic monk and spiritual teacher, said the following. He said, in order to gain possession of themselves, they have to have some confidence, some hope of victory. And to keep that hope alive, they must usually have some taste of victory. We must know what victory is and like it better than defeat. Victory is when you're treated like a human being. Victory is when you can look upon yourself with some compassion, like you never have. Victory is when you realize that despite all that's happened to you and despite all that you've done, you're still a worthwhile human being. That's not the kind of victory our system gives people. It's the very opposite. The politicians thrive of creating enemies out of the most abused segments of the population. They thrive of creating fear of them. They thrive of adopting and advocating punitive, harsh attitudes towards them. May God forgive them. Because what they're doing is they're further entrenching these people in their addictions. The research literature is very clear. The biggest driver of addictive relapse is stress. When you marginalize, ostracize, criminalize people, impoverish them, and banish them beyond the social periphery, you're simply making sure that they're going to stay addicted. So in the context of the present system, there's simply no hope for the large-scale rehabilitation and for all the good people that work in corrections and for all the idealistic efforts that they put into it and for all the individual victories that somebody in corrections or somebody in addiction treatment, a counselor or a physician like myself might occasionally witness. For the most part, the system is almost designed to keep people entrenched in misery. Thank you.
Short period of questions directed at Dr. MatÃ. Yes, sir.
Do you have an offer of a suggestion of where we go from here?
Yeah, I think what's needed, first of all, is a massive shift of attitude. I mean, first of all, you have to understand what this is all about for them and how deeply traumatized they have been and continue to be. You know, when you look at the suicide rate amongst Aboriginals, when you look at the school dropout rate, the incarceration rate, I mean, in a country that's supposedly dedicated to freedom and equality, what other segment of the population could suffer those consequences without it causing a national outrage? And our country is spending $11 billion in jail. Well, what I could, on jails now, the present government is, what I could do with $10 billion provided to rehab and re-education, to healthcare. We spend, I don't know how many billions on supposedly bringing freedom and justice and education to the Afghanis. Well, what a joke. How about bringing it to our own population first? In other words, they would take a massive reorientation of priorities. Canada has apologized to the Japanese population for their deportations and loss of their economic goods during the Second World War. It's taken this country much longer to apologize to the native people for the residential schools. And of course, in terms of robbing people of their goods, much as the Japanese suffered, their suffering was nothing compared to the losses of the First Nations peoples. We haven't even begun to address that. So for our part, it would take, when I say our part, on the part of our society and governments, it would take a massive shift of priorities and a massive commitment to be a bit humble and honest about what we're doing and what we've done. For their part, my message to native populations when I speak to their communities is not to wait for the government to do any of that, because it ain't going to happen anytime soon. They're going to have to confront the abuse in their own communities, never, without shame, without self-blame, but they're going to have to confront it. Because without confronting the abuse question, they're never going to confront the addiction question either. All of which, again, would take a great shift of perspective. That's the first step. If we had that shift of perspective, I think the possibilities would be infinite.
Thank you. Is there one more? Right here.
What I'm wondering is it more systemic than just looking at trauma? Because the way that the Therapeutic Institute has now been slashed funding, so now the majority of prescriptions, drug studies, all that is coming from companies who are working with the state. So how do you disentangle that and get doctors to come on board? Because to me it seems like doctors need to take a stand and say, we're not going to use that new medication because there's not enough studies, or and then further on that.
No, actually there are lots of studies and they all show how addictive these drugs are.
Yeah. And then further on that, there's conclusive evidence that shows that proper counseling with drug use, proper medication use, infinitely increases the chances that those people will not relapse. However, there is absolutely no funding for psychology in Canada.
No, because we're busy building jails.
So what's
We have to get our priorities straight, right? The British Columbia government cut programs for addicted youth in the north, but it's got money to support Olympic athletes. I mean, you tell me what our priorities are. Look, the medicine is in great difficulty these days. The use of psychoactive drugs has increased exponentially in the last several decades, including the children. In the States right now, there are 3 million kids on stimulant medications for ADHD, and there are 500,000 kids on heavy-duty antipsychotics. Not because they're psychotic, but because we don't know how to control their behaviors. Because their environment has become so toxic for them that they simply are acting out all the time. The medical profession is, the stuff I told about brain development is not controversial, not taught in the medical schools. The stuff I told you about trauma, not controversial, not taught in the medical schools. The average medical doctor never hears a single lecture on normal human psychology. All we hear about is pathology. And the solution, both because it's time-wise much easier, and also because it's simpler, and thirdly because we lack that kind of training, is to hand out pills. So I just received an email this afternoon from a conference in Los Angeles where they'd like me to come and speak. The subject is the very one you raise. There's this so-called biological psychiatry these days. By biological psychiatry, they mean giving drugs to change people's biology. But the understanding that the human psychology, that the biopsychosocial nature of a human being, that their biology is actually created by their environment, and furthermore, what the UCLA psychiatrist, Dr. Daniel Siegel, calls interpersonal neurobiology, that the neurobiology, the biology of our nervous system depends very much on our relationships, that's completely ignored in medical practice, for the most part. So the doctors are very undereducated when it comes to the realities. And so, and then, as you suggest, these programs are not funded. That's the reality. When you ask me how to change that, I have no idea. I mean, I can talk till I'm blue in the face, and it doesn't matter how many studies I point to, the decision makers, that's not where they're coming from. Now, that doesn't, I'm not pessimistic about it in the long term. I think at some point sanity will prevail, and one just has to keep saying how one sees it and hope that it'll have an impact. But the short-term outcome, it's very dismal as far as I'm concerned. The short-term outlook.